Hi all, I am Dr. Pavitra and today's topic of discussion is going to be end-tidal carbon dioxide, capnometry, capnography, whichever way you want to look at it. So this is in continuation with our ventilation series. Capnometry, as the name suggests, is metric. It just tells you the concentration of carbon dioxide, whereas capnography is a graphical representation of the real-time events that are happening in the patient over time. So you get a trend from capnography. Capnography will give you more information than capnometry. A carbon dioxide can be measured quantitatively in values or qualitatively just presence or absence in exhaled air. Broadly two methods. We will see about that in just a moment. The carbon dioxide that comes out in exhaled air needs three things to happen properly. One is cellular metabolism. Only if cellular metabolism happens properly will you have a carbon dioxide production. Then that has to be carried by hemoglobin to the heart and where it pumps to the lungs. So heart has to function properly. Next, the lungs has to push the carbon dioxide out into the airways and then into the air. So ventilation. So perfusion to the lungs, ventilation of the lungs, and your metabolism has to be normal for you to have a normal carbon dioxide concentration. Just a small bit about physiology. You must have known about this Bohr effect and Haldane effect, isn't it so? The relationship between PaO2 and hemoglobin saturation is non-linear. A right shift indicates that hemoglobin is having less affinity towards oxygen, which means it is releasing oxygen fast and it is not attaching to it enough. Left shift means hemoglobin is having increased affinity to oxygen. So as from looking from outside, it will look as if an increased affinity means good, but in reality it is not so. You want the hemoglobin to release the oxygen to tissues. If it is having too much affinity, as in the case of prolonged hypocarbia or prolonged alkalosis, then you end up with tissue hypoxia. The implication for us here in an end-tidal carbon dioxide measurement is this: your pulse ox may not detect this left shift or Haldane effect. The reason being, hemoglobin is still bound with oxygen, isn't it? So that is what your pulse oximeter reads. But only if this oxygen goes into tissues, your carbon dioxide will be produced. So EtCO2 can give you a good measure of tissue hypoxia also. Okay, where your pulse oximeter just tells you the hemoglobin saturation with oxygen. So coming back to this, capnometry is just the amount which says a particular value at 30, 35, 40, 45, and it can be done by two methods: infrared spectroscopy or color change colorimetry. Infrared spectroscopy depends on the principle of carbon dioxide absorbing this 4.26 micrometer of infrared light. It can be measured by using a mainstream device or a side stream device. The mainstream device has the disadvantage of adding to the already existing dead space, and side stream device has the disadvantage of recording the carbon dioxide values slowly. A color change colorimetry depends on the principle of the chemical substance changing color in the presence of carbon dioxide, which means this is just qualitative and it is not quantitative. Plus, once it changes color, you will not be able to use it again and again, so only a short span of usage. Plus, this has got a very high sensitivity. Even a small amount of carbon dioxide presence is going to change color. Overall, a capnometry says a number and it has got no diagnostic value, and it can be diluted by bias flow. Bias flow is the continuous airflow in the ventilator tubings even during exhalation phase. We saw about that in the previous classes. Plus, the high sensitivity may work as a disadvantage, giving false positive. See, if you are going to intubate into the esophagus, a small amount of carbon dioxide will still be there. Color changing colorimetry will change color because a small amount of carbon dioxide is there. So you end up not knowing whether you have intubated the patient tracheally or esophageally. So the high sensitivity gives a false positive reading and it does not work as an advantage to us. On the other hand, a capnography is a real-time graphical representation of the carbon dioxide exhaled, and you can assess this by having these four QRST forms. Q stands for quantity. The normal EtCO2 or end-tidal carbon dioxide is 35 to 45 millimeter of mercury. R stands for rate. Respiratory rate depends on age, and increased or decreased respiration can change your capnographic waveforms. S stands for shape, where it's usually rectangular with rounded corners, and T stands for trend, where the QRS is supposed to be consistent, stable, or improving from the previous worst state. The capnography, apart from being a real-time indicator, may in fact be the earliest indicator in case of a worsening patient. Imagine a patient who is suddenly going apneic on a ventilator. Okay, the ventilator will go to a backup mode, yes, but in the small amount of time where in case you have not set up a backup mode, or due to whatever reason patient is not being ventilated at all, your pulse oximeter will still take some time to represent the saturation going down. The lag time will not be there in end-tidal carbon dioxide or a capnographic measurement. It will immediately flatline saying the patient is not being ventilated. Hence, you will have a very early indication that something is going wrong with the patient. This is a standard capnographic waveform. Okay, so there are 4 phases. Phase 1 represents the inhalation phase. During inspiration, there is not much carbon dioxide at all. So, that is the baseline. It should not be more than 2 millimeter of mercury. Anything more than that or increasing baseline suggests that the patient is rebreathing the exhaled air. Phase 2 represents exhalation. This exhalation air it constitutes the anatomical dead space and some amount of alveolar gas. See, whatever stays up is going to go out first, isn't it so? So, whatever air is there in the airways goes first, then whatever is in the alveoli will start coming out next. This rapid upstroke represents anatomical dead space air and alveolar air, and phase 3 is only alveolar phase. Carbon dioxide from alveoli alone are going to come out. That's why at the end of phase 3 you have your end tidal carbon dioxide, which actually represents the alveolar carbon dioxide that is present. Once the patient starts taking a breath, immediately this plateau falls down, and this is phase 4 and again goes back into a baseline. So, if you want to look at it in more depth, you have the baseline, which should never be above 2 millimeter of mercury. You have a rectangular waveform, and this upstroke, rapid upstroke, depends on the resistance of airways. Too much resistance, you will not have this rapid upstroke, resulting in a sawtooth pattern. And this angle between this transitional phase and the plateau phase or alveolar phase is represented by alpha angle. If the airway resistance is too much, if in case of an obstruction, then there is incomplete exhalation, the alpha angle will not be formed at all, or it will be more than 90 degrees. This angle which is formed between this alveolar phase and this rapid downstroke is called as beta angle, and it may represent your rebreathing. I will have to check on this point again, and I am having doubts in this. So, this is about your capnographic waveform, normal capnographic waveform. What about the changes? So, this is one where the patient was breathing okay, represented by these normal waveforms, and suddenly it is flatlining. So, this flattening of trace could be due to a problem in metabolism, perfusion, ventilation, or an equipment failure. If there is no metabolism, no carbon dioxide is going to be formed. If there is no perfusion, as in a cardiac arrest, again no carbon dioxide, hence flatlined. If there is no ventilation, as in apnea, respiratory arrest, then no exhalation of air, no carbon dioxide. If all of these are working fine, equipment is not detecting the carbon dioxide exhaled, then again you are going to have a flattening of curve. A common thing that you should be looking for is your ETCO2 monitor disconnection or your ventilator tubings disconnection, because even then you will have a flattening of trace while the patient is actually being ventilated. Next is a bifid wave. So, this is a normal wave, and here you have a small bump. This bifid wave represents an endobronchial intubation suggestive of differential ventilation of lungs. Say you have your ET tube in your right lung. So, the first phase, this upstroke, means the exhaled air from right lung comes out first, and the second phase is suggestive of the left lung carbon dioxide escaping. This will not happen if the ET tube is cuffed and it is cuffed tight. The second wave will not be there, so you will not be able to make out an endobronchial intubation. The third is the sawtooth appearance. As you can see, there is no upstroke at all. This upstroke is not happening because airway resistance is very high and the exhalation does not happen properly. In fact, throughout this period, the dead space itself has to take so much time to empty. The alveolar phase does not happen at all. So, this sawtooth appearance or shark tooth appearance is called as, or is suggestive of, a bronchospasm. There's no alpha angle there. If this shark tooth has a bent part, then the spasm or the narrowing of airways is due to a mechanical problem, and even the ventilator's increased turbine function is unable to overcome this fixed obstruction. In this fixed obstruction, both inspiration and expiration will be affected. The inspiration is suggested by the lesser steepness rather than a vertical downfall, and expiration, as you can see, there is a slow transitional phase rather than the rapid transition. Here you can see oscillations. You can have oscillations like this, or you can have oscillations like this. These oscillations are suggestive of a large heart whose pulsations are transmitted to the lungs. Next, you have a wave in which there is a small cleft. This cleft is called as Curare cleft, which is suggestive of paralytic agent being used, or the patient is trying to breathe. This is representative of patient's breathing effort. Then you have a condition where the carbon dioxide waveform is low. There is low carbon dioxide, and what could be the reason? Decreased metabolism, as in hypothermia. No, carbon dioxide is formed, but it is not being shifted to lungs because of a cardiac problem. It can be hypovolemia, it can be hypotension, it can be the heart not pumping properly, or it is pumping but it is unable to reach heart due to a pulmonary embolism. Or this is also okay, this is also okay, but there is problem in lung getting this carbon dioxide filled air out. Okay, if too much hyperventilation has happened, then too much carbon dioxide would have gone out already, and the end result is a low carbon dioxide concentration. Or if the patient is apneic, the patient has extubated, self-extubated, or if there is an airway obstruction, then the air is not going to escape out, or very less air is going to escape out, hence low carbon dioxide concentration. Then apparatus malfunction, yes, obviously. The opposite of that is increased end-tidal carbon dioxide. As you can see, the waveforms keep on increasing continuously. Why? It could be because of increased production due to increased metabolism, as in a fever, or you administering too much sodium bicarbonate, extra perfusion, ventilation problems, as in the patient is rebreathing or hyperventilating, resulting in too much buildup of carbon dioxide in blood, hence too much carbon dioxide in your end-tidal carbon dioxide also. How do you differentiate these two? See, if you have increasing baseline, it is suggestive of rebreathing. If you do not have an increasing baseline, then rest of the causes should be considered. This sort of waveform where it looks almost normal except for this end upstroke. This is called as a pigtail capnogram, where there is a poor compliance of lungs. This poor compliance of lungs means this poorly compliant alveoli is trying to squeeze out the end part of carbon dioxide out into the air. So this results in small upstroke at the end. This happens also in obese patients and in pregnant patients. Last but not least, there is increasingly recognized role of end-tidal carbon dioxide in cardiac arrest. One being you finding out that there is a cardiac arrest by rapid flattening of capnographic waveform, even before your ECG or pulse ox detects. ECG may not detect because there can still be electrical activity in the heart without the heart actually pumping. And pulse ox, we saw the reason earlier. Next, in a cardiac arrest patient, you do two things, right? You try to place an advanced airway and you try to do compressions. Advanced airway placement confirmation you will get by appearance of proper capnographic waveforms. Next, feedback about effective compressions. If you are doing effective compressions, you are giving good perfusion. If you are giving good perfusion, then your EtCO2 rises to more than 15. Ultimately, your aim is to perfuse the vital organs, right? And because of these two, you expect the patient to have a return to spontaneous circulation. This is represented by sudden rise in EtCO2. So usually the waveform is flat because patient is arrested. Then you are trying to do a cardiac compression, which is evidenced by the small EtCO2. Then this rapid upstroke, if this happens, it means patient has a spontaneous circulation. This might even be higher than 35 to 45 because whatever built up PaCO2 is there is trying to get out. Then last but not least, this will give you a good guidance for length of resuscitation. This is an area that is still being researched, where during compressions, if the EtCO2 is staying above 15, then this might be considered as a continuation or indication for continuation of resuscitation, because even after 1 hour of resuscitation, patients have come out with good neurological faculties intact. What's the relationship between your PaCO2 and EtCO2? The ideal situation is where both are equal, but we never have an ideal situation, right? It's usually within 5 mm of mercury to each other. The reason being alveolar dead space. This alveolar dead space will actually dilute the exhaled carbon dioxide. That is why EtCO2 might be slightly less than that of your PaCO2, but never high. So you consider EtCO2 as normal or in relation with your PaCO2 if it is within 5 mm of mercury, and it should be less than PaCO2. If it is going to be not related, where your PaCO2 is very much high compared to that of entitled carbon dioxide, the meaning is carbon dioxide is unable to get out of the blood into the exhaled air. Why? It could be decreased perfusion to lungs or problem in ventilation of lungs. Decreased perfusion is heart is not working properly, or there is no blood, or the blood is unable to reach lungs. Decreased ventilation of lungs, it could be due to too much auto-PWP, or the equipment calibration is wrong. I think that's all about your entitled carbon dioxide. We have covered everything in not too much expansiveness, but at least overall I think all of you have an idea. Thank you guys for listening to me patiently. If you have any doubts, you can let me know down in the comments below. I'll definitely help you out. And share this video among your friends, your colleagues, your juniors, seniors, and in your academic groups. We'll all learn pediatrics together. Bye bye.